Well, let's start. So today will be about acute severe asthma, exacerbation in children, and the main is about ventilation, nothing else about that. We will mention some of others, we will like move on it very quickly of other topics other than ventilation, but our main talk will be ventilation of asthmatic patient. So the objective would be giving some introduction and then talking about general principle and also supportive care, sedation and paralysis, and then we'll talk about the intubation, mechanical ventilation, indication goals, oxygenation, ventilation, and strategy. And we'll talk about some adjunct therapy and then complications, and we will end with weaning. So first is the hospitalization rate in USA is about, so Dr. Iman, your name has a doctor and it's only one name. I will allow you today to be N, but next presentation you will not be allowed. You need to write your names without salute, without prefix, just your name. So there is about 500,000 admissions in USA of asthmatic patient to PICU. And you can see that the mortality of asthma was increasing until about 1996. And after that, the mortality rate of asthma is somewhat plateau or stationary. So, and the reason because the prevalence is increasing, but the care is improving. Sorry for the interruption, but people keep coming in. And there are many people who are using nicknames. Are trying to go in, so they are not allowed. So who should be, again, sorry for interruption. I'm sorry, the technical help is done. Joseph, we've told you to join earlier for technical help. I was waiting for 10 minutes to help, but you did not join. So right now we cannot help you. So who should be admitted to an ICU? Sorry for that. I was keeping those who need corticosteroid. Most of those need corticosteroid. They will need admission, or those who's on very aggressive bronchodilator therapy. Those who also need very close monitoring. Use of non-invasive ventilation will definitely help to avoid invasive ventilation. Mechanical ventilation should be reserved for those who continue deterioration despite continue deterioration despite other supportive measure, and they might end up with respiratory failure. Use of mechanical ventilation has been associated or use of mechanical ventilation during asthma exacerbation has associated with morbidity. And the reason not for ventilation because the level or the severity of asthma is very high. Mortality due to complication after PICU admission are very uncommon. Mechanical ventilation rate for babies or for children with asthma is somewhere between 1 to about 20%. It depends on the center and the severity of the cases. When you need to ventilate, always consider it very early in the course of the disease. Best way to avoid ventilation is rapidly escalate pre-intubation management and your trajectory to prevent worsening. So you always need to monitor the work of breathing and the CO2 level. The intubation that happen in emergency, usually it's a very short duration. And because most of this intubation is unnecessary. While intubation, when the patient goes to the PICU, usually lasts 2 to 3 days. Mechanical ventilation with asthmatic patient is very challenging because there is airway obstruction, there is improper exhalation, and also you need to escalate the setting of the ventilation, and therefore you might expose the child to the paratrauma. Tracheal stimulation during intubation, remember that when you try to intubate, tracheal intubation itself might decrease the oxygen level, and that may cause hypoxia. There are 10 people waiting. They're using nicknames. They are not allowed in. So if you know anybody who is using nickname, not his real name, not doctor, not Nokia, not Iraq, not anything, then if not only one name, his full name, then he's not allowed in. So if you know anybody who is not using his real name, then tell him that he will not be allowed in. So again, a mechanical ventilation in asthma is challenging because airway obstruction and because of impaired escalation and because the risk of paratrauma. And remember, when you intubate, you are stimulating the upper airway and you might cause hypoxia. Also, you might cause, if you take long time, you might cause mechanical obstruction and cause increased CO2 or hypercarbia. Now, when you start primary assessment, it's not different. Abir, Muhammad, Shita. Questions and comment will be at the end of the talk, not now. So when you assess a patient with asthma, it does not differ from any other problem. You have to start with your airway. And the question will not be answered even if you chat. We'll answer the question later. So airway, you need to make sure your airway is clear, maintained or not maintained. You need to know if there is foreign body. You need to know how to use the advanced intervention. You need to know the positioning. You need to know how to care the, when there is an injury, your head tilt and chin lift. So anyway, airway assessment of asthmatic patient is not different from any urgent patient assessment. You start by the airway. And the second assessment will be about breathing. So you need to know all your background knowledge about how to assess breathing, including your respiration, how to assess, how to monitor. You define tachypnea, you define not bradycardia, but bradypnea, or low respiratory rate, what's the orgonal gasp, and all that sort of assessment you need to know. That's not our goal. And also you need to assess whether you are inadequately expanding and there's any asymmetry, and all that sort of breathing assessment when you assess asthmatic patients. Also, you need to know how to monitor asthmatic patient. What is your SAT monitor? What's your target? What's your target in a premature baby? This is not the purpose of our talk today. I'm just passing it over. Also, you need to know how to recognize a respiratory problem, like when you have low or hypoxia, when you have alveolar hypoventilation, when you have defect infusion, or you have mismatch, or you have right to left shunt. You need to know how to manage and how to target. This is, again, not our purpose talk today. Also, you need to know the difference between upper, lower airways and lung tissue disease and disorder of breathing control, and how to differentiate between them. This is from Pulse. Again, you need to know. You need to know. Again, you need to know to recognize your deterioration, your airway maintainable or not, your breathing. Okay, well, let me see who's texting me. Okay. Anybody who's not hearing me, text me, please. If you don't hear me, text me, please. So you need to know how your airway, your breathing, your circulation, your disability, and your other assessment when you assess a patient with. Sorry, people are keep interrupting me. Nobody tried to follow the rules. And then you need to do your initial evaluation, your airway, your breathing, your circulation, and then you start your intervention. So then you divide the asthma exacerbation to mild to moderate, and what you do with mild to moderate, you need to give oxygen, you need to give my Matador inhaler. Matador inhaler. You need to give some puffs, and it's every few hours, and then you need to increase it if there is no response, and you need to assess. You need to give nebulizer below 2 years. This is not the purpose. And then you have moderate to severe, and then you need to escalate your Matador inhaler albuterol and how many times you give, and then you need to decide about nebulization and increase the severity. Again, this is not the purpose of our talk today. And then when there is impending respiratory failure, you need to recognize that. You need to know when to switch from inhaled or nebulizer to IV medications. You need to consider steroid earlier. You need to watch your oxygenation. You need to watch your consciousness. All sort of that things is out of the side of the purpose of talk today. Then when you admit a patient and you sort of deal with all non-ventilation issues from monitoring and assessment and all sort of that things, you need to think about your supportive measure. So you need close cardiopulmonary monitoring, you need SAT monitor, cardiorespiratory monitor, you need to think about analgesia, sedation, you might think of using muscle paralysis, you need to give support to prevent breathing stackling, which means accumulation of the breath 1/1, and then we'll talk about it. Do you guys hear me? Do you guys hear me? Can you text me, please?
Yes, we can hear you.
Okay, so please, I'm gonna again then, for those who does not hear, ask for help, and you need to join earlier because you're keeping interrupting me. So if you need help, you have to join earlier. If you're using a nickname, you will not be allowed to go in. So also you need to think about breathing stackling. We'll talk about it later. You need to think about your ventilator dysynchrony. We'll talk about it. Also, you need to think about your IV fluid. You need to think about your blood pressure, and you need to think about other supportive measures. And then you need to think about sedation and paralysis. The best, a list of like fentanyl, and fentanyl has some sedative but mostly analgesic effect. Midazolam is a very good because it's short acting and it can be given as infusion. Also, ketamine is a very good for induction of intubation and for maintenance of sedation, and also has a bronchodilator effect. Propofol is mainly for induction of intubation. It's very hard to give it as an infusion. Etomidate as another medication that you use. You need also to think of neuromuscular, whether you use paralyzing or non-polarizing. And when you sedate, the main sedation is to promote patient ventilator synchrony. That's the whole purpose of sedation. You need to make the patient and ventilator matching, working together. If they start to work in two directions and you get patient ventilator asynchrony, then your sedation is not good. So remember that in asthmatic patient, the main purpose of sedation is to make the patient synchronize with the ventilator. And you need to blunt the tachycardia and the tachypnea. These are very important because the more tachypnic is the patient, the more autopeep that we were talking about, and the more barotrauma that you will get. Today, I will not talk about fentanyl or about morphine or about midazolam or even lorazepam. These medications are worse, but I'm going to talk about ketamine because the most commonly used facilitator for intubation. And it's a synthetic derivatives from phencyclidine. It has bronchodilator effect, it has sedative effect, and it can be used to induce intubation and also can be used to uh, um, it can be also used for continuous sedation as an infusion. And it also can be used with non-invasive ventilation. You give it as a loading dose and then a maintenance dose. However, with all that being said, there is very limited real evidence about use of ketamine in intubation and sedation, about control of PA2 or FiO2 ratio, about dynamic compliance, about level of CO2 or level of PIP. The other is propofol. It can be used to facilitate intubation. It's a very strong hypnotic, and it's been used in anesthesia. And because it is causing global central nervous system depression through activation of GABA. It decreases metabolic rate, and therefore it decreases the intracranial pressure. So when you intubate for any increase in intracranial pressure, it's good to use propofol. It has anti-inflammatory effect. It dilates the central airways. And again, it's used to facilitate intubation in asthmatic patient, but it's not being used to maintain sedation. However, there is some report that propofol may be used bronchospasm. We've said that propofol can cause bronchodilation, but sometimes in some patients can cause bronchoconstriction. And these are when you have history of atopy, when the asthma is induced by drug, and the other type of asthma, any other type of asthma, like let's say asthma with infection, it has a bronchodilator effect. So when you have a drug induced, when you are atopy, it can cause bronchoconstriction. Not absolute, but mostly will cause bronchoconstriction. And there are lots of complications associated with prolonged use of propofol. That's why it's not advisable to use it as a maintenance. It's only used for induction. And these complications occur more commonly when you're using corticosteroid, which is usually the case in asthmatic, and when using catecholamines. And therefore, there is box office warning from FDA of using propofol as maintenance of sedation. There are several studies have been published about using propofol for sedation, and they thought that is not good for sedation just because uh, the dose was assessed, that was assessed for prolonged use was because it's higher dose. So there are a study that is being done in 500 PICUs, and they use a less dose, and they were able to use it in less than 48 hours for maintenance of sedation without obvious. Other, we said fentanyl, midazolam combination is very good. And there is a drug which is called dexmedetomidine. The dexmedetomidine is a selective alpha-2 receptor. It's from the family of clonidine and guancine. However, the clonidine and guancine are non-selective. They, they agonize alpha receptor in general. So dexmedetomidine is very good because it has less respiratory depression, and therefore you can use it safely sedation for non-invasive ventilation. You can start with loading dose and then you give maintenance. The main problem with this is hypotension. So you have to give the loading dose and then measure blood pressure and give another few interrupted dose and measure blood pressure after, and then you can go with infusion. And you have to start with lower infusion rates than increase. So dexmedetomidine are very good sedative for both invasive and non-invasive, and has less respiratory effect, but the main problem is hypotension. And the other use of dexmedetomidine in addition to non-invasive is adjunct sedation. So if you're giving sedation like fentanyl and you're getting side effect like hypotension or other side effect like dependence, you can start with dexmedetomidine as adjunct to decrease the dose of other sedatives and analgesic like the narcotics. Um, um, Also, the as I said, the dexmedetomidine was used for non-invasive ventilation, very clear because of no respiratory depression. The neuromuscular blockade, they can be used as a temporary, especially those very short acting like the cholecystine or acetylcholecystine, the succinylcholine, or you can, so it's very good to use it for intubate. And if you have a clear asynchrony between the patient and the machine, and the sedation and analgesia is not working, you might need to give muscle paralysis. And the one of the use is either a coronium or pancronium. You can use it 0.5 to 1 milligram per kg per dose, and then assess. So usually it's an interrupted dose or it's a non-scheduled dose, and you give it every 2 or 3 hours. The most important side effect is myopathy. So if you're using other drugs that cause myopathy like steroid, be just very careful of using it because it can cause very serious myopathy. And when you use muscle paralysis, if you remember when we talked about mode of ventilation, we talked about 3 types of breath. We've talked about mandatory, given by the machine. We've talked about spontaneous, done by the patient, no support. And we talked about assisted breath, where it starts by the patient and giving help to the patient. So when you give muscle paralysis, you have to use rate enough in mandatory, because there will be no assisted, there will be no spontaneous. So remember, that's very important when you give muscle paralysis, to use a mode and a rate that giving the enough mandatory breaths. And as I said, example of muscle blockade is recoronium. When you intubate and resuscitate and take care of the patient, you need to have your resources like ventilation bag, your self-inflation bag. I'm not going to talk about it. You also might use flow inflation bag. Which is the anesthesia bag. You need also to know how to hold the patient, how to position, how to make real tight seals. This is not our talk today. You need also to have the parameter of good ventilation, how to assess improvement. Again, this is not the purpose of our talk, it's just for you to read it. When you intubate, you need to have your checklist of pre-intubation, what exactly should be available, and also what is the machine you use and how to assess, and whether you're using oral or nasal intubation, what's the size of the ETT, what's the level, how you check good placement, how to assess. All sorts of these things is not the purpose of our talk today, but I put it there just for you to know. As we talked earlier, manipulation of the upper airway of asthmatic patient during intubation can cause airway obstruction and cause hypercarbia. And also manipulation can cause airway spasm and can cause increased oxygen requirement. And before you intubate, you need to make sure that you have adequate IV access to give induction medications or RSI, rapid sequence intubations, or you want to give other medications. You need to make sure that you measure your blood pressure, either use it as a peripheral cuff, put the cuff over there, and set the blood pressure monitor to check the blood pressure every like 15 minutes or every 30 minutes. And if you have an arterial line, then you should have a continuous monitoring of your blood pressure. You need to make sure you're very well sedated, and not very well, but properly sedated. This is not a pneumonia patient. This is not a premature patient. This is not a heart failure patient. This is asthmatic patient. He's air hunger, he's strong, and you can have a complication very easily. So you need to optimize your sedation. You need to be very expert to intubate asthmatic patient. If you want to if you're novice with the intubation, it's better to start with heart failure or with pneumonia or with a premature or with a term baby rather than asthmatic patient. Or you can practice people who need surgery, because these people are easier to intubate. And if somewhat you're late in intubating, then your complication might be less. So if you want to intubate asthmatic patient, you should be very expert in intubation. And when you intubate, you have to be ready for complications, malposition, tube obstruction, pneumothorax, or when your equipment failed. And also when you give medications for induction, you might get hypotension, very common complications. When to intubate? When to intubate asthmatic patient? If the patient cannot speak, if he's confused, if he has pain, if you got hypoxia, you're using non-invasive ventilation, you're getting 100% FiO2, and you're not getting SAT, your target SAT. Hypercarbia is not an indication for intubation of asthmatic patient. However, increasing CO2 is an indication. What does that mean? If your CO2 is, let's say 70, that's not an indication of intubation. But if your CO2 60 and then becomes 70 and a few hours later become 80, then that's an indication. But 80 itself is not an indication to intubate. Other indication is hypoxia, as we said. If you give 100% and you're not reaching your maximum SAT, whether you're using mask or nasal prong or using non-invasive ventilation like CPAP, and your PaO2, if you have arterial blood gas, less than 60, then that's an indication of infection. If you're increasing work of breathing, which means that the patient cannot speak, he will be exhausted soon. This needs intubation. If he's confused, altered mental, if you have respiratory or cardiac arrest, maybe stop breathing. Not hypercarbia. Remember, hypercarbia itself is not an indication to intubate. But remember, when your CO2 get higher, you get drunk. Because when you drink alcohol, the part of alcohol that causes you drunk is CO2. So the more your CO2 is higher, the less you will be conscious, and then you start to be drowsy. So very important when your CO2 is increasing to intubate, but hypercarbia itself is not an indication to intubate. When your work of breathing is increasing and you think that the patient will have a respiratory or muscle fatigue soon, that's an indication for intubation. Before you intubate, you need to make sure that the patient getting enough oxygenation. When you intubate and after your intubation, the first 2 hours of increasing CO2 is acceptable, because ETT in the airway, the endotracheal tube in there, can cause an obstruction. And then you have to wait and be patient, especially if your pH is normal. The goal when you intubate is to have the lowest side effect. So when you intubate and your patient is going toward deterioration, put the patient on bag, whether it's a self-inflation or a flow inflation, and start to bag and monitor your amount of pressure that you're giving, because that will help you to set your ventilator. And in addition, it will help you to bring your saturation up, because the more the patient is saturation is better, the easier to intubate. And then also monitor the amount needed to fully expand the chest. When you compress your bag, there will be time. So if you can observe that time, it's very good, because that will help you to determine the inspiratory time. Remember to prevent breath stacking or stackling, which is piling of the breath, or it's accumulation of the breath, or the patient start to breathe so fast that breath will come 1 over 1, and then as if you are not breathing. It's like an oscillator, because stackling or accumulation of the breath, the previous and the next, will not allow the PIP to go down to the original PEEP, and therefore the next breath will start earlier before it reaches to the PEEP, and therefore you create what we call it auto PEEP. And if you create auto PEEP, you get higher volume or higher functional residual capacity, and that will cause you more trauma, because it will cause you more paratrauma. And also when you get auto PEEP, you will decrease the preload, or the amount of the venous return to the heart. And also you will, because the pressure is high, you will get some increase in pulmonary vascular resistance. So it's very important to remember to decrease your respiratory rate and to give enough enough expiration to prevent the auto PEEP. And therefore you should have a normal respiratory rate, Normal mean normal inspiratory time and very good time for the expiratory time. When you intubate, you need to maintain a good airway saturation. And remember, very important to remember that asthma is not an alveolar problem because your inflammation targeting your airway. And therefore, when you sort your bronchospasm, your oxygenation is improving. So most of the times when you intubate and you sedate the patient, your saturation improve and your oxygenation should go down. However, when you have hypoxemia or low oxygen saturation or low PiO2 level, that is not related to asthma. It's either you have a plugging or obstruction, or you have atelectasis, or you are doing hyperinflation, or you have a ventilation perfusion mismatch. Because remember, asthma is not alveolar problem. When you intubate, oxygen should improve. If it does not, then these are the problem you have to look for them, and we'll talk about them. The first things that you can do to improve your oxygenation, if you don't know what to do, is to give more oxygen. Atelectasis usually result from mucus plug, but there is another reason for atelectasis, which is when you give excessive oxygenation. Because remember, oxygenation will be absorbed very quickly, and then you have a collapse. So you need to make sure that you are not excessively giving oxygen. So how to improve atelectasis from mucus plug? You give enough PEEP. And also you do frequent suctioning. And to do frequent suctioning, you need a good sedation. And then you need to position the collapsed lung to be the upmost. So if it's on the right, it should be right up. If all these measures does not, then start to increase your PEEP. And increase your PEEP by 1 centimeter of water each time. Remember to prevent hyperinflation, because hyperinflation may generate zone 1 physiology. And zone 1 means you have excessively dilating your alveoli and you don't have enough perfusion. And zone 1 is the upper part of the lung. And that will cause mismatch ventilation perfusion. Because when you have excessive ventilation, there will be not enough blood coming to take your CO2, and you accumulate your CO2, and there will be not enough, although you have a very good amount of oxygen in your alveoli, but it's not taken to the body. And because of that, it will be absorbed and will cause more atelectasis. So it's very important to prevent hyperinflation, and we'll talk about it. And remember, hyperinflation will cause barotrauma. Risk of hyperinflation can be reduced by the following. First, you need to decrease your tidal volume. How you decrease your tidal volume? You're decreasing your minute ventilation. So your minute ventilation is your tidal volume times your respiratory rate, which means if you decrease your respiratory rate, you will decrease your hyperventilation. If you decrease your tidal volume, you will decrease the hyperventilation. And when you do that, when you drop the rate, you will have time for, you will have a good expiratory time. So the patient will have enough time to get rid of the air. And then when you drop your rate, you'll get normal TI. And which means the ratio between inspiration and expiration will get longer. So you have shorter inspiration and longer expiration. And because your dominator become bigger, your ratio will go down. And your risk of paratrauma decrease when your hyperinflation is less, but also when your PIP is less. And we'll talk about the PIP. Now, PSV, or pressure support ventilation, is ideal for asthmatic patients. However, remember that PSV is driven by the patient, not the machine. You are only giving a pressure. And remember, if we talked about the pressure, the whole idea of the pressure, or the whole creator of the pressure, is the peak of the flow. Remember, volume is the time of the flow, and the pressure is the peak of the flow. So you're only giving a flow, and you're giving higher flow. And the machine and the patient should drive the machine. And because the asthmatic patient difficult to ventilate, they need you good sedation, then if you are over sedating, the patient might not be able to drive the machine. It's exactly when you have a drunk patient, a drunk person driving a car. So it's very important to remember PSV is ideal because it's all done by the patient. There will be no air trapping, there is no complication, there will be no asynchrony, but remember, the patient should be able to do that. So if you're using PSV, you have to put a good backup rate. Then always remember to give permissive hypercarbia, or what we call it, controlled hypoventilation. Which means you allow higher level of CO2 before you intervene. The reason for that is, remember, increasing CO2 has no major side effect on the body. It's actually decreasing CO2 would affect the body by causing damage to the brain. So if you have high CO2 but a proper pH, then you can allow that, and that's what we call it permissive hypercarbia. So do not overventilate, just to get rid of your CO2. And remember, when your CO2 go up slow, then your buffering system in your body can control to keep your pH. So if your pH is more than 7.25, then accept whatever you're getting from CO2. But if your pH getting lower and lower, you might need to escalate your ventilation to bring your CO2 lower down. However, when you do permissive hypercarbia, your cardiac function should be okay. Your contractility should be good. Your blood pressure should be good. And remember, presence of concurrent chronic conditions is against hypercarbia or permissive hypercarbia. When you have a cyanotic heart disease, or when you have a cardiomyopathy, or you have a pulmonary hypertension. There are lots of people waiting, but they're using nicknames, so I'm not allowing them in. I've already told that you need to change your name because I need to know who's entering. Using a nickname like iPhone won't help. Other potential contraindication of hypercarbia is increased intracranial pressure. So if you have a condition causing high cranial pressure, then you should not use a permissive hypercarbia. If your cardiac function is deteriorating, or if you have other metabolic problem like renal failure, also you should not allow permissive hypercarbia. You should control your CO2. Now, what is the mode that you can use during asthma? The best would be what we call it pressure control ventilation, or the other name is assisted control ventilation. So this will be for the mandatory breath. But if the patient is having also spontaneous breath, you can add with this ventilator, you can add PSV. So for your mandatory, you will use pressure control ventilation, or we call it assisted control, the other name. And if your CO2 is okay, and you have no hyperdynamic or hyperinflation issue, you can allow the patient to take the spontaneous breath. And when he does that, or she does that, you use a hybrid mode of PSV in addition to help the spontaneous breath. The other type of is what we call it volume control ventilation. And the best volume control ventilation is pressure regulator volume controller. And you can see it control the pressure and it control the volume. It looks like assisted control with the VG or volume guarantee. So if you use VG with AC or PCV, then as if you are using PRVC. But PRVC is mainly for adult. The other way that you can use a pressure control SIMV or volume control SIMV. And remember, SIMV will only give the mandatory because it's synchronized, intermittent, mandatory. There will be no assisted breath. There will be no spontaneous breath giving help. So when you use SIMV, your patient will receive what you said to them. These can be pressure control in older patients. It can be volume control in young patients. So the volume control ventilation like PRVC or the volume control type of SIMV is giving constant, not consistent, constant tidal volume or minute ventilation. Because when you fix the rate and you fix tidal volume, you get constant tidal volume. The other parameters in the ventilator will be set according to the interaction between the patient and the ventilator. So minute ventilation or tidal volume and respiratory rate will be the independent factors. All the others will be dependent factors. So changing resistance and changing compliance will determine other factors. In pressure regulated volume control ventilation, you assure that the patient getting enough tidal volume, but with the lowest possible PIP. So, which means the PRVC, it's exactly like assisted control when you add to it VG. So if you have AC VG, it's exactly same like PRVC, but the machine are different because not all the machines that give PRVC will give you ACVG. So again, volume control PRVC or volume control SIMV is the most ventilator that's used in asthma. You determine your tidal volume and you let other parameters to be set according to the interaction between the patient and the ventilator. And therefore, your PIP, your P plate or the plateau phase of the inspiration or the distance between peak PIP and the plateau will be changeable. And it will be determined by the airway resistance and your other adjunct therapy. We'll talk about it. It might be confusing. So if you remember from the basics of ventilation, this graph. So you can see you have PEEP here, and then your ventilation start. And start the flow, you're giving flow until you reach PIP or maximum. This represents upper airway. This part of inspiration represents upper airway until you reach your peak. And then from your peak to your plateau phase represent the airway resistance in the lower airways, in the small airways. And from the plateau phase to the PEEP, it represents the alveoli. So from here to here, you represent the resistance. From here to here, you represent the compliance. So if this goes up, that means your pressure in the airways is up. If the distance between PIP peak and plateau is higher, mean you have lower airway resistance. If this comes closer to this, or the distance between plateau phase and the PEEP, then you have a alveolar issue like atelectasis or plugging or collapses. So it's very important to look at this graph and determine where you are. Now the disadvantage of PIP elevation, you get airway resistance. Because the more PIP, the longer the period it takes for the flow to reach to the alveoli. And also when you have mechanical obstruction, you get higher PIP. And then when you get atelectasis. The volume control of ventilation, and remember, all this we're talking about volume control. The volume control is very acceptable and preferred by many PICU specialists. Using PRVC with or without paralysis. So if you want to use PRVC or you have other mode and you want to switch to PRVC and you set your right and tidal volume, however your PIP is going more than 35 centimeter of water, or your P plat or the plateau phase is more than 30 centimeter of water, then you need a paralysis. It's very important. Otherwise, you will get hyper trapping and hyperdynamic respiration. So it's very important to look on your PIP and your P plat when you're doing volume control. The caveat of using volume control, if you have high PIP and P plat, then you might need a neuromuscular blockade. So that's the caveat or the disadvantage. When you use a neuromuscular blockade, try to use the minimum dose. So if you are using ricuronium, try to use 0.5 to avoid myopathy, especially if the patient is on steroid. Or otherwise, you have to drop your PIP if you cannot use muscle prolongation. If you already use sedation and you want to avoid muscle paralysis, then try to avoid or drop your PIP. Now, the PRVC is specific for Servo 300 and Servo I. Also, some of the SIMV volume control have a machine that provide SIMV, can provide PRVC. And the whole idea of both is you set your tidal volume and let other parameter to be set by interaction between the patient and the ventilator. And PRVC offer both, as we said, volume control, but also the pressure control. It's very important when you use PRVC to have optimal deceleration inspiratory flow. So if your deceleration is not straight or concave, then you have airway obstruction. It's very important. But the advantage is you assure your tidal volume. And it's used the minimal PIP to get your tidal volume. The pressure control, however, and an example is pressure control type of SIMV, you set your PIP. However, your tidal volume will be changeable. It will be a result of interaction between the patient and the ventilator, and therefore it is a dependent variable in this time when you use a pressure control. And therefore, it be affected by airway resistance, compliance, and hyperinflation. And remember, the resistance is the first part of the pressure graph, and compliance is the lowest part of the pressure graph. So you might end up with hyperinflation because your tidal volume is variable. And therefore, your minute ventilation, which is the result of respiratory rate and tidal volume, is not assured because you are only determining the pressure. Example of the pressure control is pressure support ventilation. And remember, pressure support ventilation, it's everything driven by the patient. So you're only giving a pressure. And remember, how you determine the pressure is by peak of the flow. So when the flow stops, the patient will cycle. And therefore, PSV is a flow cycle. And in PSV, there what we call a demand valve. So when the patient needs, the valve will trigger the ventilation. And therefore, the preset pressure is sustained during inspiratory flow. And the inspiratory flow that creates the pressure, it should be 25% of the maximum value. So therefore, the clinician set the final airway pressure, and the minute ventilation will be variable. Increasing PSV pressure will decrease patient effort. How to increase the pressure? By maximizing the flow. PSV also, because everything is driven by the patient, there will be less. It's the least mode of dysynchrony, because the patient is driving everything. However, the patient should be able to drive. So when patient has high CO2, he will not be able to drive. When the patient is on sedation, he will not be able. So you need to make sure that he was able to. But if he is, then the least. The other things is PSV is the least invasive of the invasive ventilation. It's exactly similar to BiPAP or non-invasive ventilation, but it's invasive. But again, in PSV, your tidal volume is not set, and therefore your minute ventilation is not assured. The SIMV is two types. It can be volume control when you set the tidal volume, or it can be pressure control when you set the PIP. And because it's SIMV, it helps only the mandatory breath. The spontaneous breath will not be helped. Therefore, you will not have assisted breath. However, always your respiratory rate is synchronized with the patient. If it's not synchronized, then it's IMV. And if you don't have SIMV in your machine, you need to sedate very well or give paralysis. Otherwise, asynchrony will happen. So SIMV, you need less sedation than IMV. You need to make sure that to give backup rate. And if that does not happen, then the patient will take a breath during that period. And when you give a backup rate, you need to give a very good interval. As we said, the SIMVs are of two types, volume control and pressure control. The preferred measure is to use volume control for the mandatory, and because the SIMV will not help the spontaneous, you combine it with PSV to help the spontaneous breath. That will be a great mode if you have the machine can do that. When you do your ventilator setting, consider the physiological the main physiological derangement of the asthma, which is airway obstruction and atelectasis. But you need to minimize your hyperinflation. When you minimize hyperinflation, you minimize your barotrauma. You always need to do chest x-ray and auscultate, and you do blood gas. What's your initial setting? When you set an asthmatic patient, your tidal volume, the initial should not exceed 10. However, maximum, you can reach up to maximum of 16. Respiratory should be somewhere like that. Don't give more than 16, even if you're a young patient. Because when you give more younger, whoever doing that, can you please mute your, I don't know why I have to say that many times. Can you please mute your mic? Whoever unmuting his mic, can you please mute your mic? So when you give higher rate, the problem, you won't have a good expiratory time. And therefore you'll get air trapping. Very important. You need to use a good inspiratory time, which is usually 0.5 to 1 second. And the maximum inspiratory time is 1.5. Don't give more than that, because otherwise you will not have a good expiratory time. And if you don't have a good expire, you'll have air trapping, you'll have auto PEEP. And therefore your ratio is always, should never exceed 1 to 3. Your inspiratory flow that determine your pressure, the maximum, because 4 to 10 liter per kg per minute, it's a milliliter, it's a liter, yeah, it's a liter. And it's 4 to 10 the maximum. It always should not exceed 10. The minute ventilation, which is the tidal volume times the rate, should never exceed, or should always be less than 115 mil per kg per minute. When you do ventilation, you should have an ABG. Indwelling is better. Stab or just sampling of outline is not good. It helps you to get blood sample, but also you can monitor the blood pressure. When you do intubation outside PICU, you don't need arterial line. Usually when you intubate in emergency, you did not give enough adjunct therapies like bronchodilators and glucosteroid and glucocorticoid. FiO2, when you set your ventilator, always start with 100%. Remember to drop it as quickly as possible to less than 0.5. Always maintain your CO2 more than 92. If your PEEP is, if you're reaching a PEEP more than 10, then you can lower your target to less than 88. Prolonged use of 100% in asthmatic patient, it will result in what we call it resorption atelectasis, because the alveoli will be filled only with oxygen. There is no other particles, there is no water, there is no other gases, there is no CO2, and it will all be absorbed and you get collapse. So it's very important to drop your FiO2. Set your respiratory rate to be the lowest to keep your minute ventilation. Less than 115, which is the tidal volume that you set times your respiratory rate. The maximum, usually the start maximum is 16. You might need to go higher, very rarely, but usually that's the, when you do that, you will avoid hyperdynamic, hyperinflation, and air trapping. Your tidal volume should not be more than 6 to 8 mil. Your peak PIP should always be less than 40. Your P-plat should be always less than 35. And when you do all these, you will prevent hyperinflation and paratrauma. If you are using more than 50, if you are using tidal volume or volume control and your PIP become more than 40, then drop your tidal volume or sedate the patient. But remember, when you drop your tidal volume, your CO2 might increase. So either you have to solve this or accept it as permissive hypercarbia. Because if, assuming that you don't have other problem that is not appropriate to use, permissive hypercarbia like cyanotic congenital heart disease or cardiomyopathy or renal failure. GIT, your inspiratory time, your expiratory time, you should not use more than 1.5 inspiratory time. Your respiratory rate, it's very important to set it in a way that you have a very good expiratory time to prevent accumulation or stacking or piling of your breathing. An example, if your cycle is 6 seconds, then your respiratory rate is 10. And if your inspiration expiration ratio is 1 to 5, then your inspiratory time is 1 second. Maximum in expiratory time will allow complete exhalation, avoid hypercarbia, prevent dynamic hyperinflation, and also prevent intrinsic PEEP, which is starting of next breath before the first breath end. And then you create auto PEEP or PEEP above the PEEP. I'm not going to go again. Again, we've talked about the PEEP. The minimum PEEP is used is the one need to open the ETT or maintain the ETT, which is 3.5. And that's what we call it extrinsic PEEP, which is the PEEP required to maintain ETT pressure. And then you need to increase your PEEP as required to prevent air trapping. But also remember, when you use more than 10, lower your oxygen target from 92, more than 92, to more than 88. So use the lowest possible PEEP, but avoid collapse. So I'm going to pause these. How you monitor? You need an arterial line, you need a central line, and then you need a cardiorespiratory monitor. Now there is other inhalation medication or bronchodilators. You can use it with invasive and non-invasive mechanical ventilation, but it's better to avoid because it can cause more obstruction. So when you are intubated, it's better to use an IV bronchodilators. However, you can use inhaled bronchodilators with non-invasive and with invasive ventilation, but you have to have a good people and monitoring, and also good support if your ventilators or your breathing machine is failing. When you use the adjunct therapy, when these are not enough, you have a good bronchodilator, you are on steroid, you are ventilating, you are sedating, and you're giving paralysis. The adjunct therapies are inhalational anesthesia and ECMO. In short, do not use them. If you won't use them, call anesthesia. ECMO is a heroic measure. It can be very good in a very well-designed, high-level center, but most people don't use it. What's the complication of treatment? You have a complication of exacerbation of asthma itself and complication of treatment. Most important is hyperinflation and air trapping. Also hypotension, barotrauma that it might end with pneumothorax, and the myopathy. And the incidence of these complications about like less than 25%. Mostly occur after intubation. If you have acute deterioration of asthmatic ventilated patients, then think of your DOP: displacement, obstruction or malposition, pneumothorax, and equipment failure. Dynamic hyperinflation, I'm not going to talk much about it. It's a complicated. It just, you don't give time for expiration. You're giving high respiratory rate or you're giving short expiratory time. And you're causing accumulation of breathing, and you get auto PEEP. And this, we explained that previously, how auto PEEP works. And hyperinflation causes alveolar overdistension and it result in hypoxemia, but also will result in hypotension, and AMIGAS, also alveolar rupture and pneumothorax. Dynamic hyperinflation, you can read about it, but you don't need to manage it. It's occur usually in spontaneously breathing patients. So if you have a dynamic hyperinflation, you either need to sedate or use less invasive like PSV to decrease the patient ventilator asynchrony. I'm not going to talk, we already talked about it. When you have dynamic hyperinflation, you need to make sure your P plate is low, your tidal volume is okay, and your inspiratory or expiratory time is enough. Barotrauma occur from excessive pressure use and cause air leak and leads to pulmonary interstitial emphysema, or you have a pneumothorax or pneumomediastinum. You can have bronchopleural fistula, you can have tension lung 6, you get hypertension, you can get, because the alveoli is so distended and it's way bigger than the bronchial pulmonary bed, then you might get a systemic gas embolism, and you may get even subpleural air cyst. You can get hypotension. And when you get hypertension, what you do is you limit PIP, avoid hyperinflation. and use bronchodilators through the IV, whether it's a schedule or a continuous infusion. If you have hypotension and you don't know what's going on, disconnect, as we talked about complication of ventilation. Disconnect, give manual breathe, and then you take it from there. We already gone through the algorithm when that happened. Other complication, you get infection, you can get bleed, and you get myopathy that we talked about it, and that causes weakness, either from steroid or from neuromuscular, some neuromuscular blockade, or from steroid or from other sedatives. You can get subglottic stenosis and you get aspiration. What's the outcome? The frequently needed, or the ventilation needed in asthmatic patients should be less than 1%, the invasive. Of course, the morbidity will be higher, not because of the ventilation, because of the severity of asthma. And also it has a lot of resources and increased morbidity, of course, by 3%. When you wean, the goal is to ease the work of breathing. Allow a good time before you wean for bronchospasm to be relieved, and your airway obstruction should be gone. Usually when you intubate, prior PICU, you will be able to extubate within 1 day. But when you intubate in an ICU, the more difficult patient will take about 2 to 3 days. When you get longer, you need longer, like 5 months more, you might get pneumonia or some systemic exacerbations about manipulation and the fluid and infection and all these sort of complications. You have when you wean, when you have a positive response to the therapy, your blood gas is normal, your oxygenation is normal, no more wheeze, your FiO2 go down, especially to airway, your PIP you need less to deliver tidal volume if you're using volume control. And there you'll see the improvement when you have a more spontaneous breathing, then use PSV, because the patient will determine expiratory time and will give enough expiratory time. Do extubation trial if you have adequate oxygenation and you have effective ventilation, you have normal PCO2 and normal pH. Do extubation if you have minimal setting, PEEP less than 5%, your target sat more than 90, and your FiO2 requirement less than 40. Before you intubate, wean your sedation, but it's not a must to discontinue the ventilation. We need to a degree that the patient is wakeful and strong enough. Observe the patient PICU after extubation. You might use non-invasive after extubation. Monitor tachycardia, dyspnea, and orco breathing, or hypoxia and atelectasis. And I am done, and I am open for questions. Any